Now it's my turn, and I have the unenviable task of introducing myself. So I'll make it simple. I'm an advanced endoscopist. I joined this organization about 3 years ago. I came from one of the larger organizations in the area, MedStar. We've been able to establish an advanced endoscopy program here. It's flourishing. It's doing well. And as part of that, I wanted to talk to you about something that seems to happen fairly often. What happens when there is a tumor obstructing the biliary tree? In other words, a malignant biliary obstruction. You see me standing there with a plunger because that's how I feel sometimes when I see these patients, because you have to think like a plumber. I mean, this is a very serious topic, but I am, in some respects, a glorified plumber. I have to unclog this tree. So with that, let's move forward. I have no financial disclosures. The objectives of today's talk: what does one do when an ERCP fails? What are the endoscopic options? I will lay those out for you. What are the common indications for biliary drainage procedures in that particular setting? And what is the role of a new generation of stents that are making all of this possible? These are called lumen-opposing metal stents. So first of all, what is malignant biliary obstruction? If we start from the duct and go from top to bottom, we have things like cholangiocarcinoma, which is called Klatskin's tumor. We have distal mets or lymph nodes that are compressing or squishing the duct, blocking it. We have cancers like gallbladder cancer and pancreatic head cancer. You heard a little bit about pancreatic head cancer in Dr. Yunan's excellent talk. And rarely we also have ampullary masses, which are tumors right at the papilla, which do not allow an ERCP to actually happen. So when we have these type of situations, what are precisely the indications? They can be broadly categorized in palliative versus preoperative. Palliative in the sense where there may be distant metastases and we are trying to prolong the patient's life and also at the same time increase their quality of life, versus preoperative endoscopic therapy, where we suspect that the surgery will be delayed for a variety of different reasons, and we need to bridge the patient, make sure that their bilirubin comes down and they are optimized for surgery. Other common indications, of course, cholangitis, which means an infection of the biliary tree. Patients with very high bilirubins tend to be very pruritic, where they are scratching very often. So it's a quality of life issue. As soon as their bilirubin comes down, they feel much better. And probably most importantly, a lot of patients who are candidates for chemo or radiation, their chemotherapeutic drugs will not work if the liver is blocked because they're excreted through the biliary tree. So if we or I don't do my job, the oncologist cannot do their job, and that is catastrophic. So I have to do something. Lastly, if the surgery is to be delayed by more than 2 weeks, for whatever reason that may be, then there is a role. But if the surgery is to happen sooner than that, the patient can go directly to surgery and do really well. But however this plays out, one has to have a multidisciplinary approach where you work with your oncologists, with your surgeons, radiation oncologists, and that's what we do here at BHC very successfully. So in these type of situations, how often and why cannot ERCP be the answer? Well, we are very good at ERCP. The national success rate is anywhere up to 90 to 95%. And we do about 500,000 ERCPs in the US. This information comes to us from scope manufacturers because they actually know precisely how often their scopes are being used. If we are unsuccessful, say in 5%, that still leaves approximately about 2,500 to 5,000 procedures that need to be done some other way. When an ERCP is done, even if it's done successfully, the stents that are placed tend to be blocked in about 75% of the cases at 1 year. So why is it that an ERCP doesn't work in a lot of these patients? Well, a lot of times it's due to tumor growth or there's altered anatomy that prevents the scope from accessing the bile duct. There may be, as I mentioned, duodenal stenosis where the duodenum is blocked completely, or the ampulla ends up in being a large diverticulum, which makes it very hard to cannulate. In these type of situations, we often look to our interventional radiology colleagues to rescue us. And that is a very effective approach. But a few words on this. When a patient has an IR drain placed, it is not without its own morbidity. These drains tend to cause a lot of pain, irritation, and they're very thin caliber drains, so they become blocked very often. And in many cases, a patient has to go back once a month to have the drain changed, or the drain is leaking. And these are elderly patients who have very poor mobility in the first place. So for the family, for the patient, this is a major issue. So a more elegant approach, if we could, would be to drain this duct internally, which is physiologically more accurate. So this diagram is something that is my map. I would like you to, we'll be referring to this diagram constantly as I proceed in this conversation. What you see in green is the circuit that is blocked. The black lesion is the tumor. And these blue squiggly lines are stents or interventions that I can do at various parts of the anatomy to drain this blockage. So again, one has to think like a plumber. Where is the blockage? How can I unblock it? That's unfortunately or fortunately how I think. The three type of interventions that I will discuss today are the top three. One of them is the hepatogastrostomy, which is making a hole from the stomach into the duodenum. From a hole from the stomach into the liver, B2 or B3, which is the left lobe of the liver. Endoscopic choledochorduodenostomy, it's a handful, I know. It means making a hole from the duodenum into the biliary tree. And lastly, gallbladder drainage from the duodenum, again, directly into the gallbladder as rescue therapy as well. So let's talk for a second about stents. So that is what these stents look like. There's a catheter, and essentially there's a plunger. And as you deploy this, let's see if this works. Hardly. But anyway, you see that little funnel sort of opening up, and when it's completely deployed, it looks like a dumbbell. It's got these two flanges, and these are called lumen-opposing stents. The idea is when you deploy them, they pull two structures together. And in this case, these two structures might be the duodenum and the biliary tree, so that you have adequate drainage. I'll show you a video of how this actually works,
when you hear a click,
where the person is slowly deploying the stent. You see it slowly popping up. That's the distal flange. As he keeps going, the rest of the stent also is visible, and there you go. It's fully deployed. The important thing to mention is that the tip of the stent is like a sword. It's got electrocautery. So when you start using it, it actually burrows through whatever is in its path. And you have to be very careful. You need to know where you're going. Otherwise, this can do a lot of damage. So now I'm going to show you this stent in practice. This is a case of mine to orient you. First of all, that's me. And then that's the gallbladder. We're about to get into the gallbladder. With this stent, I'm in the duodenum. So this video is speeded up. I don't usually work this fast. So here we go. So you're going to see something zip across the screen. That's the stent that just went into the gallbladder. I'm gradually going to start deploying the stent, as you see. And in a second, you'll see that the flange opens up as I deploy some more. And there you go. It just opened up. And now, as it's opened up, I'm going to pull it up so that the whole structure it's been deployed in this case the gallbladder, is being pulled into the duodenum, or right next to the duodenum, as I apply the proximal flange and I establish biliary flow. And there you have it. So now that we know what the tools of the trade are, let's look at a couple of cases. Case one. These are actual cases, patients of mine, 89-year-old female who presented with itching and fatigue. She had abnormal liver function tests in a cholestatic pattern. Bilirubin was very high, and unfortunately was found to have a 3-centimeter mass seen on imaging. Most crucially, her bile duct was 17 millimeters in size. Now, the usual size is about 6 or so. So this is crucial because we can use these stents if the bile duct is over 15 millimeters. So with this information, let's look at her imaging. These are actual images from the patient. The radiologist thought it was 15.7. I subsequently corrected him. It was about 17. But anyway, that's the dimension there. And when I went down to do an ERCP, I find this mass. There's no way I'm going to be able to do an ERCP. So what are my options? Well, I did an endoscopic ultrasound. And before I do that, I just want to point out the procedure that we have on tap. It's this CDS, choledochordioidinostomy, where I'm going to go from the duodenum directly into the biliary tree. So I like to refer to this image because I think it explains perfectly where we are. So that's the first image, endoscopic ultrasound. This black jelly bean type thing that you're looking at is actually the biliary tree. So I'm measuring it. It's about 17 millimeters. The next step, I take a needle and I put a hole in this duct, and through this needle, I pass a wire. The wire is going up into the liver. This wire acts like a railroad for the stent that's coming. And right after that, I deploy the stent. You can see that it's got these two funnels, the two flanges, both inside and outside. And as soon as I do that, I've established good bile flow. If you're curious what this looks like on the outside, it's not pretty, but that's what it looks like. You've got the stent. We're in the duodenum. The mouth is open. You've got this yellowish liquid coming out, which is bile, which is always good for an advanced endoscopist to see. It means that you haven't perforated, you haven't put the stent somewhere where it shouldn't be, then I'd be calling Dr. Salome. But when we see this, we're happy. So if this procedure is this good, why is it not first line? Why don't I do this all the time? Well, there's a few things one should understand. First of all, it is very good, yes. Stent patency is about the same at 1 year as for an ERCP. It's got higher technical and clinical success rates than ERCPs, and the procedure time is 10 minutes in the hands of an expert. So not all of us are. I certainly don't think I'm an expert, but this data comes from large tertiary care centers around the country where they think their procedure time is 10 minutes. Mine might be 30 minutes. Most importantly, if you do this procedure and the patient has pancreatic cancer, you can still do a full resection, which is R0. In technical terms, what that means is you've extracted the tumor without leaving anything behind. So in no way does it cause problems for the surgeon later on. And this data comes from this DRA MBO trial that was pretty famous recently. What are the problems with this procedure? Well, there are two things: cholangitis, where the stent becomes blocked, and mal-deployment, where you, as I mentioned earlier, you can deploy it in the wrong location, inappropriately, or sometimes the stent falls out. These are very rare, and there are ways to fix this or prevent this. Stent dysfunction at about 6 months is 31%. Oftentimes, it's because of tumor growth. So what can we do to fix this or prevent this? Well, we have this sort of device. You're seeing the lumen opposing stent at the top, which looks like a dumbbell, and then you have a double pigtail device that, like the name suggests, it is two pigtails connected. So what if we took the pigtail and placed it through the stent after it's been deployed? This pigtail will keep the stent from moving around, so it'll fix it, and it will keep food from getting into it or tumor and so forth, and it'll keep it patent for longer. And this, we know, actually works really well. So this is standard practice. Now, this has further been modified by the Scorpion trial, where I'm going to actually show pictures. You see the scope, and I'm not sure if you can see the stent, but you can see the white line, which is the axis of this stent, and you can see the shadow of the biliary tree. I'll make this more evident like so. You see the green line. The green line is the axis of the bile duct. The white line is the axis of the stent that I've placed, and they're almost at a 90-degree angle. This is not good. They need to be parallel. So if it's 90 degrees, the stent is not going to function appropriately. It's going to become blocked very easily. So what do? In the second image, you see this long tubular stent that I placed to the first one, and now the axis, as the white line demonstrates, is almost parallel to the axis of the biliary tree. This will prolong the patient's life by at least 3 months, but this simple act of placing another stent. And we know that this works very effectively. So most recently in my practice, I have started doing this as well. All right, so moving on to the second case, similar situation, 87-year-old male, presenting with cholestatic jaundice. Bilirubin was very high. There's a question of a mass in the head of the pancreas based on the CT scan. Grossly dilated stomach, so there is evidence of gastric outlet obstruction. Most interestingly, the bile duct is only 12 millimeters in size. This is a bit of an issue because, as I mentioned, we cannot deploy that stent if it's less than 15. So I go down with a scope and I see this. There is nothing, the duodenum is blocked. You see a tumor growing, I cannot pass it with my scope. So then I look around with an endoscopic ultrasound and I see this egg-shaped gallbladder that you're seeing. It pops up and I got to thinking, why don't I drain this? So I placed that same stent that I showed you a few minutes ago, instead of the biliary tree, directly into the gallbladder. And we get this greenish bile out, and for the same reasons that I explained before, I put a pigtail through it to keep the stent patent for longer. And in the same session, I ended up stenting the duodenum, and the patient was able to go home 3 days later with eating and with normal bilirubin levels. So this is what we're talking about, just to go back to the diagram that I keep referring to, which is gallbladder drainage. What are the indications of this procedure? Well, usually this is a rescue procedure. So when you failed an ERCP and you couldn't do direct drainage of the biliary tree with the CDS, which was the first case, you can usually resort to this. But the crucial point is that the cystic duct has to be open. It should not be invaded with tumor and so forth. The success rates are very high, over almost approaching 100%. And then when you compare this with CDS, what are the pros and cons? The one issue with this procedure is that the gallbladder is a mobile structure. So as you try to perforate it with the stent, as you try to put the catheter into it, in some cases it moves around. So which means that if you're trying to put a stent into it, sometimes the stent won't go in, or it may make a hole in the gallbladder and the gallbladder is already moved away and now you're stuck with a bile leak. So it has to be done in very experienced hands in centers where you have surgical backup just in case. But overall, still a very safe procedure. A few words before we end on the last procedure that I mentioned. It's called hepatogastrostomy, which is, as I mentioned, going directly from the liver, from the stomach into the left lobe of the liver by placing a long stent. This, again, is the indications are failed ERCP, like the other ones, but where the tumor is very high in the biliary tree, so like a cholangiocarcinoma, as you can see in that diagram, where if you were to stent the distal bile duct, it would be meaningless because you need to go above the tumor. Again, you have to think like a plumber. So the issue with this is probably the highest risk of these 3 procedures because you are making a hole from the stomach through the bed of the through the bed of the liver into the biliary tree. So number 1, the more holes you make, the more bleeding you get. Number 2, these distances can be more than 3 or 4 centimeters, which make it very challenging. Our longest stents are about 10 centimeters. So what if you deployed the stent and it shifted inside? That is a huge disaster. So again, in institutions where this is done very often, where you've got good surgical backup, this can be a procedure of choice. The great thing about this is that our hepatobiliary surgeons love this because we stay out of their way, we are well above their field, so in no way does this impact their surgery. So what are my takeaways? If there's a failed ERCP, there is life beyond it. There's life beyond interventional radiology. We can still help. We can help ourselves before we call somebody else. Biliary drainage procedures have very high technical and clinical success. If you have a patient with biliary who requires some sort of biliary drainage, please ask yourself these questions before you seek referral, because this will help the physician you're calling try to figure out what is the best option. Where is the obstruction? What is the size of the biliary tree? Does the patient have a preference? What is the functional status of the patient? And what is your local expertise? And even if you have the local expertise, do you have the local equipment that we talked about? Ultimately, the best approach is a multidisciplinary approach where we speak with our surgeons, our oncologists, and we make the best decision that is personalized to that patient. Thank you very much. Thank you. So we're going to do a